Dr. Singh, the floor is yours.
Thank you, Dr. Hassel. Good morning, everybody. As Dr. Hassel said, my name is Kamaljeet Singh. I'm a breast and gynae pathologist in Providence, Rhode Island. And I'm excited about this session. So I believe you already have gone through the boot camp session. So you have an idea about how the tissue section gets onto the slide. So in this session, let me share my screen. So in the agenda is I have a PowerPoint slideshow of 18 slides, and in those we will go through the like an overview of this module. Let's see. Can you guys see my screen?
Yes, we can see it.
Okay. So, oh, I just moved my PowerPoint to a different screen. I have two screens. So can you still see it, Dr. Hassel?
No, we're just seeing your nice background.
Okay, let me do this again then. Stop share screen one. Okay. How about now?
There we go.
Yep. All right. So, and I was thinking about it, how to do this overview because now we are getting into a specific organ, and I would like to remind the group that whatever you have learned in the boot camp, you have to remember that. How does the, you must have learned a little bit about grossing, the gross appearance, how the sections are taken, and how do you kind of look at the sections and make a 3D impression of the actual tissue. So that's going to stay. However, we are going to add a lot of language, pathology language, a lot of terminologies. So you will be in this module, um, like any other tissue in your body, you will learn the language of hyperplasia or proliferation, then atypia, and then when does a proliferative lesion turns into a carcinoma. So in this overview, I would say I'm not going to go into a deep details, criterias, or how do the histology look, but I would ask you to keep a low, as if you will, a low power view of the lesion of the histology. So as you go through this module, you will notice that we have a section on grossing. So grossing, I can't stress it anymore. Uh, a, you can only become a good pathologist if you know how a lesion looks grossly. And in breast, it's actually pretty simple because breast is a very simple organ. So if you look at the structure of the breast, it's either fatty tissue or a fibrous tissue. So when you're thinking about a breast, you are thinking about either a mass lesion or something else like calcification or asymmetry. And you will notice there will be some radiology lingo also. So you have to kind of get used to, if you're looking at a breast tissue, you will have to get yourself a little bit used to what is radiology saying. And also, what is the clinical presentation? So all of that is going to come into picture. Learn a little bit about normal histology of breast. As I said, it's relatively simple, but you really need to know where you are in the breast. Are you in the parenchyma? Are you near the skin? Are you near the nipple? Are you near the skeletal muscle? So there's something called the fibroglandular boundary of the breast. So one of the goal during the module is keep it in your head. Can you tell that where are you by looking at a slide? And always keep that in mind. So you'll notice that the breast tissue, in breast tissue, we will classify many breast lesions as proliferative. They are since you know the breast is a hormone sensitive organ, and the epithelial lining of the breast tissue undergoes hormone dependent changes. And some of them are increase in number of cells, which we call proliferative lesions. And at some time, these proliferative lesions jump into the category of proliferative lesions with atypia. So something to keep in mind that learning the histological findings that differentiate these proliferative lesions from proliferative lesions with atypia. Now, depending where you are, in the US at least, if in your place you're doing a lot of screening mammography or screening for the breast cancer, you will be exposed to a lot of proliferative lesions and proliferative lesions with atypia. However, if like I come from India, I got my initial training in India, and I have international fellows from Philippines, they don't see proliferative lesions with atypia as much, like a typical ductal hyperplasia. So in your mind, you have to also keep, you should be aware of the progression of the disease. Where do you see the disease or the lesions in your country or in the location where you are? Like in US, we see it at different stages during the early stage, precursor lesion, at the carcinoma stage, at both in situ and invasive. And we often see tumors that are lower stage, T1, T2. But you might be seeing in your residency, in your training, tumors that are larger and overt. But just keep that in mind, that where are you seeing those lesions. The module also talks about biomarkers. Breast is an organ where many of the biomarkers were actually started. The estrogen receptor, progesterone receptor, HER2 is one of them. So in the module we talk about how do you interpret them, what are the cutoffs, how do you use them, to classify the breast cancer. It's really important, and they make the cornerstone for the treatment of breast cancer. So that's very important. Breast does not have a lot of immunohistochemistry use, but there is some critical. So we talk about, we learn about a little bit of immunohistochemistry, myoepithelial cells, how to differentiate in situ versus invasive. And we report them in the biopsy and excisions. I also want you to learn, how do you know what is the standard? How do you make a diagnosis? What words do you use in a diagnosis when you are creating a report? It probably may not be very critical in the early stage, but it's a good idea to start thinking about it. So there are some resources. So College of American Pathologists, they have a synoptic sheet. AJCC, they have standards on how do you stage a tumor. So you really need to know about that. And yeah, when you're going into organ specific pathology, every lesion, every tumor in the organ has a different way of staging, which predicts or which tells you the prognosis. So you need to learn that, because your physician, who is your customer, and the patient, who is your customer, they are interested in knowing the stage of the disease based on which the treatment is decided. Also, you need to know depending on where you are, some of the guidelines that your breast surgeon, breast radiation oncologist, people who are treating the patient, they may be practicing some standards of care, and they may be, so in US we do NCCN guidelines. So I would say at least you should know about these. They are freely available, and we do mention it in the module. So know about the standard of care. WHO Blue Book, it may be a good time to at least know about it. So it's the consensus guideline which tells you about how do you classify the breast tumors or breast lesions. So those are your resources which guide you. How do you classify, treat? Now, these are all the epithelial lesions. Breast, like on other organs, you have to keep in mind that breast can have non-epithelial lesions, and that includes spindle cell lesions. It can have vascular lesions. They are rare, but you have to keep in mind that breast tissue is composed of epithelium and stromal tissue. So it can have both kind of proliferative lesions. And of course, the other large category is inflammatory lesion. So if you keep this table in mind, and then you go look into your histology details, eventually you will have to kind of put your histology together into these categories. So talking a little bit about how do you orient yourself when you're looking at a breast slide, okay? So whenever you have a section from breast tissue, whenever I have a section, I try to think, okay, where is this section taken from? So this is just a cartoon showing a breast tissue. So you have a nipple, large lactiferous duct, and then it divides into smaller ducts, and which ultimately end up into these blind pouches, which are the terminal duct lobular units. And each of them, it's important because depending on where you are, you get different kind of lesions. Most of the breast lesions, they are arising from the periphery of the breast. So you rarely see any lesion arising below the nipple. There are some, so if you know where the lesion is, where the tumor is, you may be able to guess, okay, what you're looking at. And then you have to add more details. So we will look at some examples as we go through. So here in the background, the section is from this terminal duct lobular unit. And you will hear this word multiple times in the module also. TDLU, terminal duct lobular unit, the structural and functional unit of the breast. The idea is most of the lesions that arise in breast, they arise from the TDLU. Just keep that broad idea in mind and then look at the section. So here is if I have to just present one slide, this is the one slide that you can, this is the process, or this is the entire process. You will be doing some of this whenever you're looking at a slide and trying to figure out what am I looking at and if you have to work it out. So just like any other organ, I would say you need to know the clinical findings. It will just, in the end, makes you a better pathologist. So you need to know the age of the patient. What's the presentation? Most of the time it's going to be a mass. Family history is important. As you know, many of the breast lesions, especially the cancer, 10 to 15% are hereditary. They have a genetic hit. Personal history, patient has a history of breast cancer or not. Location of the lesion, as I said. So next is gross finding. So there are in a module, I think first section is on the gross. How do you submit sections? What do you look for when you have a breast tissue serially sliced? Is many times, especially if you're dealing with the proliferative lesions, the lesions are grossly inconspicuous. But most of the times, the lesions will come as a mass. Is it a cyst? Is it skin-based? And the gross finding might be important for the staging of the tumor. So if you have for example, if you have a pretty circumscribed lesion in the periphery of the breast, you're probably looking at a fibroadenoma in a young patient. If it's stellate shaped, you're probably looking at a cancer. If the lesion is really close to the skin or near the chest wall, it may not be something related to breast. It may be a fibromatosis or something arising from the chest wall, a mesenchymal tumor. If it's just below the nipple, it could be a papilloma, which is the most common lesion that you see just below the nipple. So knowing where you are, where the lesion is, will help you kind of make up your mind. And then, of course, you look at the histology. For the sake of time, I'm going to skip through the rest of these, but what you do, and all of this is covered under the module. When you're looking at a slide, you have to decide what kind of a lesion is it. Is it epithelial? Is it epithelial stromal? Is it inflammatory? Is it vascular? List of ancillary tests. We go through this. And the ultimate goal is that you're able to combine together the histology findings to make a diagnosis and give that diagnosis to your surgeon or radiation oncologist who can take the findings and decide on the treatment. Now, I'm just going to go over a few quick examples that will kind of help you understand what are you going to go through the module. So, for example, fibroadenoma is the most common mass lesion in a young patients, young women, premenopausal, and then you will learn how do you diagnose a fibroadenoma, and then there are multiple variants of fibroadenoma. So you have to kind of keep in mind what is a fibroadenoma. So it's a combined proliferation of epithelial structure. These blue lined spaces, these are epithelial structures, and then this is the stromal tissue that makes it a fibrous and adenomatous component, fibroadenoma. And then based on other findings, you can classify it into one of those 6 types. At the same time, I would ask you to think about etiopathogenesis of each and every lesion. So keep in mind you have to record what you're looking at, but at the same time, if I tell you this entire lesion, fibroadenoma, is derived from this TDLU. So essentially what has happened is, so these all blue circles, these are the epithelial component, and the pink connective tissue is the intralobular stroma. Both of them have hypertrophied and increase in number to create this fibroadenoma. So knowing that, etiopathogenesis helps you understand, okay, where is this coming from? Why is it in the periphery of the breast? Moving on, you will go through these slides, which will show you examples of, on the left side, you have a proliferative lesion. You will learn the lingo. So hyperplasia, just try to understand, might have to go back to your second year medical school. What is hyperplasia? Increase in number of cells, right? And then ductal, it's inside the duct. And then usual is for benign. Atypical means it's neoplastic. So new terminology, kind of similar, but big difference. Another example, radial scar. The reason I show this is there are terms, there are things that we have named that are misnomers. Scar, there is no scar here. Scar means there was an injury, there was reactive fibrosis, but radial scar is kind of a misnomer. And a lot of this is a lesion where you really need to know the radiology of it too. Why? It's a totally benign lesion. In breast, we biopsy a lot of benign lesions, especially when you have a screening mammogram. So there are lesions that mimic cancer on radiology. So this is one of the lesions that mimics cancer, and that's why we will sample it. Quick example of apocrine cyst. Why would we call it a cyst? So a cyst is an empty space that is lined by true epithelial lining. The question to ask yourself is, why are always the apocrine cysts clustered? And the clue is etiopathogenesis. This entire lesion is derived from one TDLU. Imagine each of these blue round spaces turning into individual cysts. That's why they are clustered. So paying attention to the histology, but also asking the questions that are kind of in the background. Why are these clustered? You will notice subtle things once you have maybe gone through middle or you're kind of at the end. Things like adenosis, and then adenosis involved by this. So there's a little subtle difference between the top and the bottom portion of this proliferation. And you can only pick by using immunohistochemistry. So the ECAT and immunohistochemistry shows that the bottom part, there is a loss. So this IHC, I don't know if you were exposed to IHC, maybe very early, but there are pictures, there are scanned slides how do you use immunohistochemistry? Usually the signal is brown, the positive signal is brown. I would ask you to pay attention, where is the brown? So in this particular case, it's E-cadherin. E-cadherin is a membranous protein. It is expressed on the lateral and the basal portion of the cells. So here's your acinus, strong brown, as compared, you look at down here, you see this kind of cells that are lost. There's no staining. There's a overt difference. So this is loss, and it confirms that, oh, you're dealing with something abnormal. Think about how the quantity is relevant. So here's an example of 3 lesions which kind of are similar. So this is atypical lobular hyperplasia. This is lobular carcinoma in situ. This is pleomorphic lobular carcinoma in situ. So they are related. Only difference is quantity. And we grade lesions. There is a concept of grading which will be introduced when you're looking at the carcinomas, both in situ and invasive carcinoma. I'm going to skip through this. When you're looking at the slides, pay attention to what's going on in the epithelial component as well as in the stroma. And I think idea is just to register what's different from what you have seen in the normal. So you may have to look at, we have some scanned slides of benign breast tissue, normal breast tissue. I would spend a lot of time on those in the beginning. So you want to learn how does normal breast tissue look like, and then look at the pictures, slides of abnormal, and see how is it different. Is there increase in cellularity in the stroma? Do the number of cells inside the ducts, they look different? Is the lining little different? Is it apocrine? And then you record it and then put it together. So this is an example of a stromal lesion. It's a pseudoangiomatous stromal hyperplasia, where you see this increase in cellularity, and some of these cells are forming these empty spaces, which will make vascular spaces. So it's called pseudoangiomatous stromal hyperplasia. I think this might be my last slide. This is again going back to the etiopathogenesis. So there are many lesions in the breast, like one I showed before, the lobular neoplasia. This is how the lesions, they kind of progress. The difference is the quantity, and how proliferative lesion, which is benign, columnar cell change, is linked to atypical lesions, eventually to the carcinoma and invasive carcinoma. So keep an eye open. So there in the module we discussed this, and also we have published literature which is peer reviewed, and there are original articles and some reviews which out there they talk about it. So keep an eye open for those the links between the different stages of the disease. It will help you build a solid foundation of breast lesions. This is the last slide, I think. Yeah, papillary lesions that will come. It's just an example of how you have to understand almost in every portion of this module what defines this entity. What is papillary? What is a papilloma? What is a papillary frond? Once you have identified that, then you go to the next stages, because then you further classify the lesions based on what else is going on. So what ties all these lesions, group of lesions in breast, is presence of papillary architecture. So when you are on this topic in the module, try to identify why would I call this papillary? And then you go further, look at the more histological details, and try to classify it into a particular lesion. So I think that's my last slide. And I think if we are ready, Dr. Hassel, for the next part of the...
Okay. Very, very good, Kamaljit. That was a very good overview of kind of what's in the module. I want to say at this point a couple of things. One is um, we don't want these sessions to be one-way sessions, of course. So this is not just us talking and you listening. There are things that we learn from each other, even as I learned things as listening to Kamaljit this morning. And there will be things that we, as your mentors, can learn from you as well. One of the ways to do that is to center our discussion around cases and having some of that material presented by you as the participants in these sessions. So I would like you, each of you, to be thinking in your experience or in your what you can find, or even in seeing things that you may read in the literature. Are there cases that you could present for discussion? They don't need to be fancy, complicated, unusual cases. They can be very straightforward, bread and butter cases that can be presented with a brief history, a few of the pertinent findings, and maybe a few images based on what you're able to obtain. So, with that, I would like each of you to begin to plan for cases that you will present around this module, if possible, of the breast. And over the next couple of sessions, when we have that presentation or have that the chance to meet again, we'll call on you uh, to do that. Now, actually, the call on you, give you the chance to prepare in advance. So, if you already know a case, then send me or Kamaljit your name and so forth. Text us, let us know that you're willing to present a case in these sessions. So, any questions about that? I'll put this out as a general email reminder for those who aren't here as well, so that they can begin to prepare. But I think in doing that, we'll be able to make these sessions much more fruitful for you because they'll be answering your questions. It will be more peer-to-peer interaction as well. So we have several of our mentors on the call with us this morning, and we're going to go into breakout rooms now with one or more of the modules, unless there are questions that you as a group would like to bring up. Is there anyone who has a question they want to bring up before we divide into the breakout groups? Okay, so I'm going to create two breakout rooms and we'll assign you to one of those rooms. And I think each breakout room will have one or two mentors as well. Okay, so room one. Okay, the rooms are opening and just about evenly divided, and you can leave and break up from your rooms when you're finished.
It spreads it spreads to the lymph node. So in those patients, or if it's a triple negative means the tumor is not expressing estrogen receptor, progesterone receptor,
Mhm.
or HER2.
Mhm.
Those two scenarios, patients have a high chance of getting neoadjuvant chemotherapy. Okay. And the idea is with chemotherapy, sometimes the entire tumor disappears. It's killed by therapy. That's perfect. Sometimes it shrinks. So
Mhm.
it's easier to do the surgery. So going back to the grossing, the reason I mentioned it, many of the breast tissues that you will gross, they will have neoadjuvant therapy.
Oh, okay.
So it's important to know, did this patient have neoadjuvant therapy? Because imagine if you just go in and say, oh, I got three breasts to gross. This is my first breast. Let me slice it at 3 to 5 millimeters. So first you orient a breast tissue, right? You want to know
Mhm.
where is the, and if it's a mastectomy, you want to know where is anterior and posterior. If it's smaller mastectomy or a partial mastectomy, you want to know the six margins. And usually the surgeons, they will orient it. And the way we uh, find out under the scope which margin is which, we ink them with different colors. Okay. So every department,
Mhm.
you will notice that you will be inking the surfaces. And then I slice them. I serially section the breast tissue and I don't see
Mhm.
anything. What do you think happened?
Because of the therapy, I think they
Yeah.
kill the cancer cells.
Yes. So it means, oh, patient had excision. I don't see anything. What happened? And even at that time, if you don't check the record,
Mm.
it's not going to be good because you don't know what to do. You may find, so in US at least, whenever they biopsy a tumor, they leave a metal clip.
Mhm.
That's how we identify where the lesion was. So in the videos that you will watch in the module, you will notice, so you ink the specimen, you kind of know what the history is, then you serially slice it, and you will notice that, oh, we found the metal clip. The metal
Mhm.
clip tells you where the biopsy site was, right? Where the
Mhm.
lesion was. And of course, you may be able to see the lesion. If the it was done for a 2 centimeter tumor, you will see it.
Mhm.
But if the person had chemotherapy and the lesion is gone, the clip will tell you that's where the lesion is.
Okay.
All right.
Mhm.
So, what I'm telling you is there can be different scenarios. So, unlike you may learn in colon cancer or in lung cancer, there are some standard ways of grossing. Okay. You may do the same thing, same set of things with every specimen. But in breast, as you said, it is difficult. The grossing is difficult. And the reason
Mhm.
it's difficult is you have to kind of adjust what are you going to do based on what the patient had. What was the diagnosis? And then did she get chemotherapy or
Mhm.
not? And then what do you see when you slice it? So there are
Mhm.
so many variables. And then you decide, okay, now I've sliced it. Now, based on those scenarios, once you have serially sliced the breast tissue, you have to decide, what do I sample, how much I sample, and why am I doing that? Why am I sampling that? Right? So
Mhm.
imagine, let's take a scenario. Same thing. Patient had tumor, had
Mhm.
chemotherapy, neoadjuvant chemotherapy, had a part. I'm going to throw some, language here, which you will see. The patient had
Mhm.
partial mastectomy,
Gosh.
which means
Mhm.
they didn't remove the entire breast.
Yeah.
The surgeon sent you the tissue,
Mhm.
and often you will find they will put a stitch marking the superior, a stitch marking the lateral.
Oh.
a single stitch superior, double stitch lateral, and it can be different. You receive it as a resident, okay? Now you're like, okay, I know the history. The patient had tumor, had a chemo, it's marked. First thing you do is you ink the external surface, 6 colors, right? Anterior, anterior, medial, lateral, superior, inferior. Now, I always palpate. You can kind of palpate the tissue because breast is fatty. You palpate, try to see if you can feel anything, right? And then serially slice it. By serially slicing, I mean you as if you're, I don't know if you imagine a bread loaf and you're bread loafing you cut the bread into thin slices. Same thing you do with the breast tissue. You bread loaf it and you try to keep the tissue slices thin. Ideal is 3 millimeter, but it's very difficult. You can keep it 3 to 5 millimeter. And then you put all those slices on your table and you look at them. You're looking for, okay, do I see any lesion? Where is the metal clip? One more thing that I didn't mention is before you do the grossing, you have to know what was the tumor size. Okay. And you will know it. You have to go to the medical record.
Okay.
Imagine in this case, the tumor size was 25 millimeters. Now, on serial sections, I don't see anything. I only see fatty tissue, no mass lesion, just a metal clip. Now I have to think, okay, what is the goal? Why? So this, I have to engage you guys. So what's the goal of grossing? Why do you want to look at the tissue under the scope? So what's the goal of histological examination of the tissue?
To confirm the diagnosis?
Well, the
Okay.
diagnosis is already confirmed because the patient had a biopsy. We know she had cancer.
Right.
So now she has
To check the therapeutic response.
So in this case, to check the therapy response. And what else? It's the goal for histological examination of almost every tumor in the body. So there is something called staging. Exactly, staging.
Okay.
So the clinicians, your surgeon, they do clinical staging. They know what size of the tumor, is the tumor in the lymph node. Now, when you are doing the grossing and you're making the slides, the goal is to give them a pathologic staging. And pathologic staging includes tumor size, lymph node status, often those two things. So now when you have your slices in front of you, you're going to measure the tumor and you will say, oh, no gross tumor identified, right? You don't see any tumor, but you have to confirm it under the scope. So in this case, you know the tumor was 25 millimeters. And you know where the metal clip is. And if you see anything like fibrous tissue, so you often, whenever the tumor disappears because of therapy, it will leave a little bit of fibrosis. Often. So the goal is, I want to submit a cube of 25 millimeter. You understand a cube? So a tissue, you kind of have to take that 25 millimeter cube out from that specimen and submit it. Because you know the tumor was 25 millimeter.
Yeah.
So you have to kind of examine that entire area of the breast tissue to confirm if there is any tumor left. That's the primary goal.
Okay.
Are you with me? Do you understand what I'm saying? Yeah? No? Let me say it again. So we know patient had 25 millimeter tumor. We are not seeing anything at the clip site. we want to, so now I'm thinking, oh, probably she had, we call it complete response, pathologic complete response. So
Mm.
I want to prove there is no tumor left. So we call that area tumor bed, where the tumor was. I want to submit the entire tumor bed. And the way
Okay.
I can submit it entirely is by submitting the tissue that is the same as the original tumor size. So original tumor was 25 millimeter. I mean, if you want to be a little bit generous, you can submit 30 millimeter of tissue entirely in that clip area. And then when you go look at your slides, so next day you will get your slides, and you are looking at the slides from the tumor bed, and you see no tumor, only fibrosis, you have confirmed it's a complete response.
Oh.
But there's a pretty good chance. So 1/3 of these patients, where you think there is complete response, on histology, you will see little tumor cells. So in order to say for sure there is no residual tumor, you have to submit the entire tumor bed. Now, this is all when you have patient with neoadjuvant chemotherapy. Let me just cover one more scenario. If the patient did not have chemotherapy, then imagine the tumor was 16 millimeters, right?
60. Okay.
16. You serially slice and you see a tumor that is, oh, okay, you see a white solid tumor that feels firm, and you measure it 17 by 16 by 15, everything matches. Now what you do, this is a different scenario, right? So typically you will submit, some places submit 3 sections from the tumor. So in order to show the largest size of the tumor, you want to confirm the size of the tumor under the microscope also. And one more thing that you do in both scenarios, neoadjuvant or non-neoadjuvant, margins. So margins are the periphery of the tumor. You want to show how far is the tumor or tumor bed from the margins. So you have to submit sample from the inked surfaces, periphery. Yeah. That's how you gross. And this was largely for if you have a mass lesion, something that is making a mass. And if you are, if you, depending on where you practice, where you train. So if you are in Asia, like if I go to India, most of the cases that I will see will be for the tumor. So these two scenarios will cover everything. Either there's a tumor or there's a chemotherapy and there's no tumor. That's it. However, we get excisions wherever there is a screening mammography, like in US, we get partial mastectomy, smaller excisions for calcifications, which are DCIS, or atypia, atypical ductal hyperplasia, which is a stage before DCIS. So when you are grossing those samples, you won't find any mass lesion. So in those, the goal and the target or the approach is a little different. When you can't see anything, you don't see any mass lesion. So then you have to, and the videos go over that. So I think there are like 3 or 4 videos. They cover the benign lesion, atypia, DCIS, post chemo, and I think there may be a mastectomy also. So I think go over those, and if you have any follow-up questions, we can talk about those. One more thing that I want to cover, I mean, especially for the new residents, or one thing I've noted is in pathology, in histology, you have to make a protocol for everything, even including very minimal thing like how do you look at a slide? You can't just come up with a new way of looking every slide, right? So what I do is I'll tell you what I do. I'll share the screen, and I'll open up. Let's see, share the screen. Where is which one? I have to open the slide. I'm going to open a slide in the Path Presenter. Okay, this one, share. And it may not be the same. Can you see my screen? Yeah, so this may not be the
Yes.
same, okay? Because under the scope, things are different, how you look, and this is digital slide. However, what I do is whenever I get a slide, I look at it grossly, I hold it, I'm like, okay, how many sections, right? So if you look at this slide, you got 2 sections. I usually start, I take my objective right here, right? And I call it, I think it's called battledore movement. You just go like this, as if, you remember the snake game that you played in the Nokia phone, where the snake goes up, down, up, down. So you're gonna go down, look at it, and then move this way, then go up, then go sideways, down, then you go this side. So it's like a zigzag movement, which covers the entire slide. You want to make sure you are looking at the entire section and entire slide. So you do that for every slide. That's my way of looking at a slide, and I do that with every slide. And it's important that you develop this reflex in the beginning. Any question? So we covered a little bit of grossing.
So I have a quick question just about the after neuro therapy about the 25 centimeter the tumor that's non-tumor. So when you submit the whole tumor bed, you mean you have to the metal click should be in the center, then the diameter is 25 centimeter.
Exactly. And you definitely want to cover any fibrotic area. So do you understand? Fibrosis, it will look very whitish. So when you seriously slice a breast tissue, you're going to see either fat or white fibrous tissue. So you definitely want to cover the fibrous tissue around the clip.
Thank you.
Yeah, it's 9 o'clock. I just wanted to check with Dr. Hassel. Can we keep going, Dr. Hassel? Or is there a
Yes, we certainly can if people have time, but don't feel obligated if you have another engagement to step off. But as long as you're willing to keep teaching, Kamiljit, I'm sure they'll be happy to
All right.
continue to listen.
Awesome. All right. Let's see if we have any other question. So
Yeah, so I have one actually. It's on the slide number 12 of your presentation. It's on the IC staining. I mean, it's just like very basic. So, for the staining loss seems to be dramatic in the lower part compared to the upper one when you were delineating the 2 different zones. So, as for a novice, how would you distinguish whether the loss is due to actually loss of the marker that you're studying, or is it due to an error during the staining process, like when you were putting the cover slipping?
yeah. So do you see my screen?
Yep.
So this is the slide that I showed. I think I went a little fast. The point was when you're looking at a slide at this stage, I think at maybe in 1 year, right? When you're looking at slide, you will be noticing at things, and you may not be noticing at very minute things. So the top part looks different from the bottom part. Okay. So there's a proliferation, there's an increase in number of cells. Let's take baby steps. And these cells are making round structures. And when you have increase in gland forming structures in breast, you call it adenosis. So these are benign glands. And the reason I say benign, everything in the breast, any epithelial structure, benign epithelial structure in breast has 2 layers. One is the luminal layer, and there is a peripheral myoepithelial layer. So I see both the layers here. So it is adenosis, I know that. However, let's compare this gland. See this gland, it has a lumen and 2 layers versus this one. The color of the chromatin. I don't know if you can appreciate the color of the chromatin. This one is a little darker, this one is a little pale. The cytoplasm is different. This is really a little bit pink, paler and eosinophilic. So this difference tells me there is something going on here. And I don't see this open lumen, right? This is also a normal gland. I don't see any open lumen in these glands. So there's some architectural difference, there's cytological difference. And then I know how lobular neoplasia looks like. So what I just described, monomorphic nuclei, pale chromatin, pink cytoplasm, and if there's evidence of dishesion. So these cells are lacking E-cadherin. When they don't have E-cadherin, they don't attach to each other, and you see the spaces between the cells, like right here. So there's a little space. So the next thing I'll do is, okay, I think there are lobular neoplasia cells here. I'll do E-cadherin. So now the observation that the membranous staining of E-cadherin is decreased, it overlaps with my histological impression and confirms it. And if it was an artifact, the artifact would have affected both this part as well as this part, more likely. This is the same section, treated in the same way, fixed in the same formalin. The chances that this loss is because of an artifact is kind of 0-0. You see this artifact sometimes when you don't fix the tissue properly. It's a good point. So if you don't fix the tissue in formalin in time, you may see this artifactual loss of protein expression. And that is more relevant when you talk about estrogen receptor, progesterone receptor, and HER2. So those are the biomarkers that we do in the breast cancer. And you will notice when you go to that module part, and especially in the first part, we have that tissue fixation times. Whenever you're dealing with the breast tissue, the moment the breast tissue is removed, you have to put it in formalin within 1 hour. If you don't, it violates your pre-analytical condition to test estrogen receptor. And the reason you want to put it in formalin in 1 hour is to avoid the pitfall of losing estrogen receptor expression. Yeah, so fixation is important. And now you can tell whether a tissue is fixed or not by looking at it. When a tissue is not properly fixed, you lose the cellular details. You lose the tissue will look a little fragmented. Tissue doesn't look intact. And you can tell, oh, this tissue is not fixed properly. It will look ischemic or a little bit necrotic. Same thing happens sometimes in your training. You may do a frozen section. So when you're doing a frozen section, you are freezing the tissue. And that leaves an artifact. Because once you freeze a tissue, you cut a section, you're going to thaw it and then fix it in formalin. So that tissue has underwent an additional step of freezing that leaves an artifact. And when you look at it under the scope as a permanent section, you can tell, oh, this tissue was frozen. So as you go through training, you look at more tissues, you will kind of train yourself how to tell these artifacts of autolysis because of poor fixation or frozen section. Other artifact that you deal in breast very often is, so surgeons, they cut by 2 ways. One is by sharp knife, okay? Other is by heat, the cautery. So when the surgeons, they cut the tissue with cautery, it distorts the tissue. It kind of burns it, and it leaves an artifact on the tissue. So when you are looking at a breast tissue during your residency, you will see this cautery artifact in excision tissues? Yeah, good question. So you have, in a way, you have to think about histology as an artifact that you can reproduce, right? So we are reproducing this artifact of fixation, staining, and looking at the cells and able to make a diagnosis. Sometimes the artifacts are introduced that are not part of that protocol. And that includes autolysis, thermal cautery, frozen section, and all that.
I have one question.
Yeah.
I posed in the breast module discussion session the problem about the pathology staging of breast cancer. Because I've read in the whole recommendation, they told that the tumor size must be the invasive component. But I don't see my friend or my colleagues uh, measure that. They just take the size on the grossing and then put into the PT staging.
Hmm.
And and how do I obtain the invasive component size to better staging?
Yeah. That's a good question, Lee. Oh, I say your name, V. Lee. So tumor staging, we do it on excision. You're right. DCIS has a separate stage. So if you only see in situ carcinoma, and it is ductal carcinoma in situ, you stage it as PTIS. All right. There's another special staging that is if sometimes the DCIS carcinoma can only involve the nipple, the epidermis of the nipple, and that is called Paget disease. And that is also PTIS, Paget. How do you stage invasive tumor? Once you have invasion, you don't stage the tumor as PTIS. The next staging of the invasive tumor depends only on the size of invasive carcinoma. Imagine you have, in a mastectomy, you have 5 centimeter span of DCIS, okay? And you are grossing the tissue. Sometimes DCIS can form a mass. You can, when the ducts are very close together, you can feel it and you may think, oh, it's a mass that is 5 centimeters. And you submit sections, and under the sections you see, oh, all of it is DCIS. The invasive component I'm seeing is very tiny few cells that measure 2 millimeter invasion with 5 centimeter DCIS. The staging for that would be PT1A. So 1A is 1 millimeter to 5 millimeter of invasion. That's PT1A. So it is important to distinguish in situ carcinoma from invasive carcinoma. And once you have identified invasive carcinoma, the PT staging will be based totally on the size of the invasive carcinoma. Does that clear? Does that answer your question?
Yeah, and my question is, how do I measure that size? H- How do I get the size of the invasive component?
How do you get the size? So you have to measure it. So there are two ways you can do it. So the recommendation is you have to measure the tumor size on the tissue when you're grossing it. So imagine you measured 15 millimeters, right? The recommendation is now you have to, once you submit the section, you measure it on the slide if the tumor is less than 20 millimeters. So you have to measure it on the slide. So imagine you have a tumor on the slide. You put the slide on the, usually what you have to do is they're made different ways. You put it on your under the scope, and people use different kind of rulers. I have this circular micrometer that I put on top of the slide and measure. It has the measurements up to 0.1 millimeter. There are some rulers. I have another one which has measurements. It's a transparent ruler, and I put it on top of the slide and align it with the invasive tumor and measure it. That's one way. If your tumor is really large, like 50 millimeter, then you can use the gross size. However, when you submit sections, you have to confirm that all of that 50 millimeters is invasive.
Yeah, thank you.
Okay.
This is my first time see that ruler on the microscope. Is it transparent?
This is transparent, and this one is actually cheap. So this one is transparent. One of my attendings gave it to me. This
Oh,
one is more expensive, but it's kind of, it measures up to 0.1 millimeter. People use it to for situations where you have to measure below 1 millimeter, and I have to do it sometimes in breast lymph nodes. There are measurements on the stage of the microscope also, and sometimes you can use it, but you have to learn how to use those. So if you look at your microscope, there are measurements on both on the two axes, and you can use them to do the measurements. But most people use the ruler, transparent ruler.
yeah, thank you. I think I will find a one ruler maybe
And
on
if you're
Amazon.
dealing with large tumors like 2 centimeter, 5 centimeter, 4 centimeter, what you really need to do is confirm what you're seeing on gross. All of that is invasive. Then you can use your gross measurement as your tumor size. You don't have to have a ruler and measure it on the slide if your tumor is really large. Okay?
Yeah, thank you.
Any more questions?
And this has been a great session, Kamaljit, and thank you everyone for bringing good questions to the discussion. Very meaningful. Don't be discouraged. There's a lot to learn, but we know that with this process you can do it. So keep plugging away at your self-study materials, and then bring questions back. Of course, if you have questions in between sessions, don't hesitate to send those off, or email some of the mentors involved here. We're always happy to cope with those questions and try to get your answers in a timely way.
Nope.
So we'll meet again in about 2 weeks, and look forward to that session.
Awesome. Nice to meet you guys.
Thank you very much.
Thank you.
Yeah, thank you very much.